Good evening, America. I'm Dr. Randy Fink, and it is that time again. It is 4 p.m. here in the Mountain Time on Tuesday, which means 6 o'clock on the East Coast, 3 o'clock on the West, and 5 o'clock in the intermediate vicinities. And welcome to Fertility with Fink and Friends. I am Fink, you are friends, and it is so nice to be here, as always, on every Tuesday evening. We've got a couple of different feeds here going on as always. We've got I've got my Instagram here. We've got CNY's Facebook and let's see, Facebook and YouTube and LinkedIn right here in the middle, and CNY's Instagram over here on the side. So nice to see everybody on this Tuesday evening with wishing a very special and happy Passover to all of our friends who celebrate, including Ileani, who is in Israel tonight, with a special thought going out to all those folks who have that missing place at the table. Still have loved ones being held hostage. Wherever you stand on the political spectrum, I think we can all agree that it is good for loved ones to be at home. So happy to have everybody here this Tuesday. Let's jump right in to see who is here with us. Well, hello, Angela. You are number one and get a very special wave here tonight, coming all the way from, I always say Wisconsin, but I do mean Minnesota. Nice for you to be here. Thank you very much, Equestrian Jazzy Poo. Good to see you, as always, David Cack. Hi, Amanda. I'm so happy that you got to be here with me tonight. Amanda is in South Carolina. And away goes Paige. Paige is here. Haven't seen you for a while. Hi to Susanna and Kelly. Hi to Zenny in Miami, and Brandis, who is celebrating her mom's birthday this evening. Please send special birthday greetings from all of us here at Fink and Friends. Let's see what we got over here on the CNY side. Maureen Fox is number one. You are number one, my friend. So special hello there to you. Money Making Mama. I like the name. And Chef Blackney, good to see you as well. Let's see. We've got Melissa, Florida Babe. Good to have you here. We've got Chris and Maggie Blevins, Molly Maroney. Howdy. What else? Ashling is here. Looks like Chabelis is here on the Facebook side. So thanks so much for being here. Hey, let's jump right into some questions here. Looks like away goes Paige. Well, actually, Susanna, you were the first with a question. Done several rounds with 0 mature eggs. What could be going on? So, I actually had an interesting situation that happened to me. Talked to a patient just this evening who had a very adequate stimulation. Everything went exactly the way it was supposed to. She was on, completely appropriate dose, was triggered appropriately, and retrieved 26 eggs. Of those 26 eggs, there was only one that was mature and it didn't fertilize, and everything else was immature. So what we typically do is we kind of hold those immature ones and look at them again the next day to make sure that we didn't miss that window of maturity. But all of hers degenerated, and that whole scenario didn't make a whole lot of sense. This is one of those cases where we typically will kind of get together with a bunch of our colleagues, with many of the other doctors involved, and run the case by and see if anybody has any other ideas. In that situation, Susanna, the first thing that I always want to look at is, at what point were you triggered? So were you triggered a little too early? Could we have, and sometimes maybe it wasn't too early. It looked like it was appropriate, but maybe we should have waited a little bit longer. Sometimes the stim in that situation is too short. And if the stim is too short, it doesn't give the eggs enough time to mature. Although the trigger shot, its job is to tell the ovaries not only, hey, we're coming for those eggs, but also it matures them. Now, each little egg is inside the follicle, and it sits on a little stalk like a flower. And so one thing that has to happen is that the egg has to get released from the stalk so that it's free floating in the fluid of the follicle. Now, in nature, what would happen then is that your body would squirt it out. It's ovulation. So the ovary acts like a squirt gun, and it squirts that out. Now, in the case of IVF, we don't want you to be squirting the egg out. We don't want you to release the egg. We want to collect it, and so therefore, we get to it beforehand, and that's why it's 35 hours from the time of trigger until the time of retrieval. And that's kind of the way that works. So, Susanna, the first thing I would wonder is there some issue with when you were triggered or how you were stimulated? Now, at the end of the day, sometimes what we conclude is that there's no recognizable problem at all. And that's a very frustrating thing. But it may have something to do with the little receptors, which are like little TV antennas that sit inside and receive the signal from the hormones. Maybe they're not receiving the right signal, so they're not getting enough of a trigger to mature. This is something that we would really kind of only be able to conclude over time. But that's certainly one of the things I wonder about. So those are the things that I would kind of look at, Susanna. Goes Paige asks, when to stop supplements during an FET cycle. When you get that positive pregnancy test, that's the time to stop. Although you want to stay on the supplements, I recommend for ongoing pregnancy are a prenatal vitamin and omega-3, the fish oil. Some people say, I don't like fish. I want to get that from another source. I want to get it from, well, that's fine. But the omega-3 fatty acids are basically something that supplementing can make a big difference in pregnancy outcomes, specifically because those fatty acids become the main component of two important areas. Number one, the retina. So visual acuity scores are better in newborns, in infants who are whose moms took omega-3 during pregnancy and during that development. And secondly, that same type of what's called a phospholipid or a fatty acid is what becomes the brain. It becomes neuronal tissue in here, the brain. So cognitive scores are also higher in women who have, in babies of women who have supplemented with omega-3. So omega-3 and prenatal, why can't they put those together in the same supplement so that you only had to take one thing? Well, because, if you've seen the supplements, you know how those things are made, right? So they basically take all these individual powders and they kind of grind them up and they compress them, compact them into that little pill that you would take orally. Well, the fish oil is literally an oil. So you've seen them before. They're little gel caps. And those gel caps, they're just a completely different material than what you see with your prenatal vitamin. So that's why they can't really be all together there. Hi to Miss Roselle. Do you recommend Molecular Fertility's IgG during and post transfer? So Molecular Fertility, which is molecularfertility.com, makes a wonderful immune supplement that you can take orally. And I think it is appropriate for a number of circumstances. I personally don't know enough about it to say that everyone should be on it, but I think if there's any concerns about the immune system, and is there ever concern about immune system in pregnancy? Yeah, there definitely is, because inflammation and immune issues are something that can prevent all of us from getting pregnant. So I think there are a lot of good reasons to use it. And so, yes, I do encourage it there, Miss Roselle. Hey to Leah, nice to talk to you this afternoon. Zenny says happy Tuesday and Passover. So, yep, appreciated there. Monica says I had a laparoscopic salpingectomy, which means laparoscopy and removal of a fallopian tube. and a polyp removal on April the 10th. How soon can I transfer? I was due for my period on April 19th, but haven't gotten it yet. So that's not an uncommon scenario that you have a little surgery, and what ends up happening is that it messes with your period because the stress hormones associated with the surgery, not to mention some manipulation and things on the inside, can just change the way those hormones are going to, your reproductive hormones, estrogen and progesterone, that sort of thing, change the way they're going to work. So not surprising that your period is a little bit late, but April the 10th. So that was about, today's the 23rd. So that was 13 days ago. I think, Monica, when you get your period, with your next period, I think everything should basically be sloughed off on the inside, and you ought to be ready to go with an embryo transfer cycle. So I think that ought to work for you, and fingers crossed. Well, let's see. John Telato. I'm sorry. Wow, I forgive my pronunciation there. Had my first appointment, and I'm so excited. I am so glad to hear that. Hey to Maggie Blevins. Molly Maroney says, do you ever give birth control to manipulate the cycle to work better for travel patients? So yes, we certainly can. We can use birth control, or sometimes even just simply estrogen and progesterone to try to manipulate the cycle so that we can have a little more control over the logistics. I personally am not a fan of using longer term birth control than maybe 10 to 14 days, because in many people, the birth control can suppress your cycle. Because remember what birth control is doing. You're taking a pill, you're putting hormone all around here in order to treat one spot down there, right? And that's really to prevent you from ovulating. Is that a good thing? Well, I mean, birth control is definitely a good thing for those who need birth control. Birth control is one of the best studied medications in the history of medical science. We know extensively about its safety. We know about its efficacy. We know how it works. We know when it works. We know who should not be taking it. We know a lot about birth control, but basically the way it works is that it's telling the pituitary in the brain to kind of basically shut down what's going on in the ovaries. And so if you're planning to do a cycle, sometimes that suppression of the pituitary gland can have a negative impact on the way your body is going to produce follicles, especially if you use it for an extended period of time. Now, there are, I will say, actually, most IVF clinics, most IVF programs will use birth control because most places batch their cycles. What do I mean by that? Why would they batch a cycle? Well, at CNY, we do about 20,000 cycles a year. Plus minus, give or take, we do a lot of IVF here. We're able to offer really the best prices in the country on IVF for very high quality, affordable care. How can we offer at these prices? Well, it's made up in the volume of the people that we can see in our different offices. And this is all comes from Dr. Kiltz's great foresight and leadership and care about the fact that we really want to make this kind of fertility care accessible to everyone, irrespective of income. This should not be something that's reserved just for the uber wealthy. But in smaller programs that typically on average do about 150 cycles a year, they may not have an embryologist every day. They don't have an anesthesiologist every day. They don't have access to the operating room every day. And so they batch their cycles so that they can do all their retrievals kind of in 1 week or in 10 days or in 2 weeks or whatever that period is. So they put people on birth control in order to manipulate the cycle so that they can have some control over the timing. We can do that, to answer your question. Yes, but do we do that routinely? Nope, because we're doing IVF pretty much every day of the week, except for Sundays. We don't do retrievals and transfers on Sundays, but the embryology lab is open. Rosa says, can I come off Orilissa and straight go to a modified natural FET, frozen embryo transfer? Yes, you can. Orilissa is a suppressive medication. It's something that we use for folks who have endometriosis. Endometriosis, we have learned how it confuses the signal between brain and uterus and why it stops people from getting pregnant. Now, endometriosis can have a couple of different mechanisms. It can cause some scarring on the inside. It can cause a decrease in your ovarian reserve, for sure. It can also take up space in the ovaries, which can create a cyst in the ovaries, which we also call a chocolate cyst or an endometrioma. Endometriosis also, as I said, interrupts the flow of communication between brain and uterus. And how does it do that? It creates this, or it's associated with an inflammatory marker in the uterus that's called BCL6. And when you are expressing BCL6 as a result of endometriosis, it takes what otherwise would probably work as an embryo transfer and make it so it probably doesn't. So when we identify that BCL6 or endometriosis, presumptively, we will suppress that endometriosis for 60 days. Some people say, well, should I do 6 months instead of 60 days? Maybe that would be better. The evidence shows us 60 days is pretty much as good as 90 days, pretty much as good as 120 days. So 60 is all you need. It's not going to cure endometriosis. And if you have symptoms from your endometriosis, such that, terrible pain and your periods are a nightmare and so forth, longer may be a better choice for you. However, if it's specifically about embryo transfer, 2 months is all you need. You can use Lupron, you can use Orilissa, you can use Myfembree. 2 oral medications, Orilissa and Myfembree, or Lupron as an injection. After that, you can go directly into an embryo transfer cycle. Now, if you're going to try to do a completely natural cycle, that may be a bit more of a challenge. And why is that? Well, because when you've been suppressed with the Orilissa, when the Orilissa has turned down your hormone function, it may take a little bit of time for you to kick that back up and to start making those hormones again so that everything works the way it's supposed to be. So I don't recommend a fully natural cycle, but you certainly can do a modified natural cycle, which is where we do some ovulation induction with letrozole, or a medicated cycle. And in fact, the data shows when you do that very first month after suppression, that's when your outcomes are the best. So not only can you, but yes, you should. Right? Good deal and best of luck there, Rosa. Hi, the IVF man. Ooh, I like that. I like the name. I do my, this comes from Ariel, like the mermaid. I do my first frozen embryo transfer on Thursday. Any tips? Excited and hoping it sticks. So, if you have the opportunity to do acupuncture, I think that makes sense. And for embryo transfer, there are 5, count them, 1, 2, 3, 4, 5 supplements that we do recommend you be on, part of an evidence-based protocol. And that is a prenatal, CoQ10, vitamin D, vitamin E, and L-arginine. Those things are all mentioned in it's a great segue. Thanks for bringing that up. My book on my ebook on supplements and fertility. You can access that book. It's a low cost at $7, and it includes a discount and some supplements if you'd like to buy them. Get it from Linktree, my Linktree, linktr.ee. Linktree/RandyFinkMD, or it is the link that is on my Instagram page. The Vitamin Victory is what that's called, and it outlines all of the supplements for fertility, for ovarian reserve, for diminished ovarian reserve, for embryo transfer, sperm quality, even folks who are just trying at home. $7 is all that thing costs, and so I think it's well worth it. in my personal opinion. Hello to all our friends over here on Facebook. We've got, looks like 19 people on the Facebook side. By the way, if just in case you were interested, if you were on my Instagram, you are one of 33. And if you were on CNY's Instagram, you're one of 36. So thank you so much for being here. Let's see. Elaine says hi. Denise says hi. Brandy says hi. Nicole says, Nicole from Syracuse, I had my first FET in January that resulted in an ectopic pregnancy. I have no risk factors for an ectopic. Why did it happen if the embryo was implanted right in my uterus? That's a great question. And so let's consult our friendly neighborhood uterus so that we are all familiar with what Nicole is talking about there. So embryo went in through the cervix into the uterine cavity. Now inside the cavity, there's an opening to a fallopian tube here on both sides. The embryo went here. How did it end up going out here and trying to implant in the tube and becoming an ectopic pregnancy? And the answer to that is because sometimes they do. There is a higher risk for a day 3 embryo becoming an ectopic because at day 3, that embryo is normally, after fertilization, is normally still floating its way down the fallopian tube and hasn't yet made it inside the uterine cavity. And so there's some evidence to suggest that for some reason that there are probably some chemical factors, what you would call a chemotactic factor, that may be pulling that embryo up into the fallopian tube where it anatomically would want to be at that developmental stage. Now, even if it was a day 5 or blastocyst embryo, there, Nicole, it can still just make its way up into the tube. About 1% of IVF pregnancies result in ectopic pregnancies, even though 100% of those embryos are being placed inside the uterus. So how does it happen? It's kind of one of those things that just does. But fortunately, the risk is generally very low. And because we follow these pregnancies so very closely, it should never be something that ends up surprising you later on with a large ectopic that ends up, really requiring surgery. Let's see, Elaine says, how can we reduce inflammation in our bodies for a successful transfer? Well, if you ask Dr. Kiltz, he will tell you that it is entirely diet related and related to sugars and what's called glycation, and that's the attachment of sugar molecules to different parts of our body that promote free radicals and things that damage different areas. So diet is a big part of that. There are some things that certain types of antioxidant supplements are absolutely associated with decreasing inflammation and by decreasing the number of antioxidants. But Dr. Kiltz believes that it's keto, and moreover, beyond keto, carnivore is a key element to decreasing inflammation in the body. And certainly, I would say, the one thing, even if you don't agree with that, what everyone can kind of agree on is that we know carbs are pro-inflammatory. Sugars are pro-inflammatory. Decreasing your carb count, your carb loads, likely does decrease inflammation. Good question there, Elaine. Bailey asked, can you transfer 2 genetically tested embryos? So a genetically tested normal embryo is called a euploid, a euploid, a euploid embryo. The recommendations are that you do not transfer 2 euploid embryos. We go by some guidelines from the American Society for Reproductive Medicine, the ASRM, and those guidelines suggest that you use 1 euploid embryo, that you would never do 2. Now, at CNY, We do give you some autonomy to make that decision yourself. We don't recommend it. There would rarely be a time that we would make such a recommendation. But if you wanted to do it and were willing to accept the risks, then in many cases, we will. But understand that placing two embryos inside does not necessarily increase your odds of a live birth. It does increase your chance of getting a positive pregnancy test, but by not increasing the live birth, that means it increases the risk of pregnancy loss. The other thing about having multiples is that it significantly increases the risk for a preterm birth, sometimes even severe preterm birth. It increases the risk of birth defect. It increases the risk of cerebral palsy. It significantly increases the risk of autism. So, these are things that we really would rather not have happen to you. We want one healthy baby at a time. And so, therefore, it is not something that we would generally encourage. Elisa asks, I have had 5 failed transfers. 3 were fresh, 2 were frozen. 2 have been with CNY. We have 2 day 3 embryos left in storage. What could we do differently to increase the chances of implantation for one final FET? Desperate. I get that. Boy, you have been through a lot. So, couple of things just to point out there, Alicia. One, we know that fresh embryo transfers are not as successful as frozen embryo transfers. So, the body has been in egg-making mode. And when you're in egg-making mode, that may not be consistent with getting pregnant mode. So fresh transfers, while some people do get pregnant from them, they will never be as successful as a frozen embryo transfer in most cases, statistically speaking. Now, what I would say for you there is that I would recommend, and we've talked about this in the past few weeks, and if you've heard me talk about it, forgive me for being repetitive, but I think it makes a difference here, and I want everybody to be aware of it. There is a medication that we can use now for recurrent implantation failure, and that's a medicine that's called Prograf. Prograf, or tacrolimus, is something that we have used in our immune protocols before. However, now we recognize, based on some newer literature, that the dosing is much higher than we thought. It's 3 milligrams per day, so that's 1.5 milligrams twice a day, or you can do a 1 milligram capsule 3 times a day, and that very significantly increases the odds of pregnancy for folks who have had recurrent implantation failures. That is, they've had a bunch of transfers, they should have gotten pregnant, and they haven't. Now, I don't know, Alicia, about your history. Some of that also depends on how old you are and what other things are going on there. But I would certainly say, without knowing anything else, Prograf 1.5 milligrams twice a day would 100% be a part of your protocol. We are taking to, actually putting people on that even without that history, because why do we want you to get that history? It's a benign medication. It's generic. It's pretty inexpensive. So this is something we're actually looking at for, pretty much everybody who's trying to get pregnant. Gabriella says, I had my hysteroscopy with you this morning. No findings. Can we do a modified natural coming up? The answer is yes. So, yes, it was good to see you today, Gabriella. Once you get your period, everything sloughs off, that lining reboots, and so you are good to go with your FET cycle, and a modified natural is a great way to do it. So cool. All right, let's see what else we got going on over here. Hi to Mariah. JM Dots is here. Is it possible to pass infections like endometriosis, ureaplasma, mycoplasma, etc., through male to female sex? If I was positive for endometriosis, should my partner also be tested and treated? So, well, I wonder if you may be confusing endometriosis with endometritis. So endometriosis is this process where the lining of the uterus that normally sloughs off when you have a period, instead of going out the door, works its way up inside and implants inside the pelvis. That is not an infectious process and is not something that is contagious. Mycoplasma and ureaplasma are sexually transmitted. Many people with mycoplasma and ureaplasma keep cross-contaminating one another, because if you find it's there and you treat one partner for it and you don't treat the other one, you're just going to give it back again. But it's also a frustrating couple of bacteria, because people can be colonized with mycoplasma and ureaplasma, which means that the bacteria just lives there. It's not an infection per se. It's not causing a problem. It's just hanging out. And the risk of it being there is that it can cause what's known as upper genital tract infections, so that it's an infection that works its way up into the lining. Now, when you said endometriosis, maybe I thought maybe what you mean is endometritis. Endometritis is that inflammation in the lining of the uterus, an inflammation of the endometrium. And yes, mycoplasma and ureaplasma are two known sources of endometritis. Now, the endometritis is something that sometimes we will test for. It's sometimes something that we will see when we do a biopsy, because it causes what are known as plasma cells. That's the immune marker, plasma cells in the lining of the uterus. And what does that mean exactly? Well, two kinds of endometritis. There's chronic endometritis, and that's the one that typically we're talking about for fertility. Chronic endometritis is a situation where you had an exposure to something that triggered the immune response. Your body probably killed the bacteria. In some cases, there can be a little bacteria in there, but inside the uterine cavity is mostly a sterile environment. There really shouldn't be bacteria there, but the immune response stays. In other words, it's like a smoldering flame. It's just this little smolder that just keeps going on and on and on. And we know that that can be difficult, make it a difficult place for an embryo to want to be able to implant. As opposed to acute endometritis. Acute endometritis is actually an acute infection on the inside. And you know you have that because you have pus coming out, you have pain, you have fever, you're sick down there. Really what we're talking about is chronic endometritis. But yeah, ureaplasma, mycoplasma are common sources. So both partners should be treated if we are treating known mycoplasma or ureaplasma. Dawn Deluxe says, I'm 39 and have an AMH of 0.645. Is a high stem better than a low, or what would you recommend? So the first place I would start there, Dawn, I mean, you got a couple of options. I am not a fan of the high dose stimulation because you're using a ton of medication. It's expensive. The more medicine you use, the more you spend and the greater your side effects. And what we know is that sometimes when you go to higher and higher doses, you get lower and lower responses. So I might think of an age appropriate dose for you rather than a high dose. And then the other option is something that we call a mini dose. Would I go with a mini dose? There are lots of folks at CNY who will say, well, with that lower AMH, let's just go ahead and start you with the mini dose because we know that it's going to give you a similar response to what you would get at the higher dose, but just with a much lower exposure to medication. My thinking is, yep, that's one way to go, or the other way to go is use a little bit more than that, use an age-appropriate dose, and let's see if we can't maximize it. But there's no one right answer there, Dawn. A lot of it is kind of just an opinion. Let's see, should IVF endometriosis patients be induced before labor or go naturally? Well, so that's controversial in obstetric circles. So endometriosis doesn't really play a role there. IVF, certainly I think that what the evidence shows us is that if your cervix is favorable by the time you are 39 weeks pregnant, the week before your due date. And when I say a favorable cervix, that means, well, there's three different measurements we take of the cervix. Is it dilated? Is it thinned out or effaced? Where's the baby's head? And then actually a fourth measurement is how soft the cervix is. So that tells us about how favorable your cervix is. If you have a favorable cervix and you're 39 weeks pregnant, there is no added benefit to staying pregnant after that. So many practices will offer you an induction of labor. Now, some people don't like the idea of an induction of labor, but of course, with IVF pregnancies, these are very hard fought and hard won pregnancies. You've had to go through a lot to get there. So when we let you go past your due date, we start worrying about risk of the placenta tiring out. And the placenta is kind of the most important feature in the whole transaction there, because that's where all the blood flow goes through. That's how the baby gets nutrition and oxygen. So we don't want to let you go for too long in that scenario, just because the pregnancy is at risk enough as it is, given how you got there. Let's see, going back over to the CNY side, Morena says, I birthed 3 children after an ectopic and I lost my fallopian tube. During my IVF cycle with CNY next month, but my AMH was very low. What are my chances? So I think it kind of depends. So what the low AMH tells us there, Morena, is that how you're going to respond to medication. In terms of what we're going to be able to retrieve. And what sort of goes hand in hand with that is going to be egg quality. So I would want you to do everything you can to try to improve your egg quality. What can you do for egg quality? There's a whole list of supplements that go along with egg quality. And again, you can get those. The Vitamin Victory is my book at the link on my Instagram, Randy Fink MD, or at Linktree, linktr.ee/Randy Fink MD. There is a protocol of about 12 different, a handful of things that have been shown in evidence-based medicine to make a difference in egg quality. Metformin is a medication that we use. Omnitrope is a medication we use for egg quality. And so these are things that I would really want to focus on in your cycles. Now, as far as the ectopics go, let's see, I think you said you lost both fallopian tubes. So we don't really have too high a risk for an ectopic, but ectopics can also be in the cervix. They can also be in the upper corners of the uterus, within the wall of the uterus. That's called a cornual ectopic. So these are things that we watch out for. Your ectopic risk is very low, but we want to do everything we can in your situation there, Marina, for your egg quality. It looks like Karine is asking, is Omnitrope expensive? It is expensive. I wish it were less expensive, but Omnitrope is human growth hormone. So human growth hormone is what keeps us young. It is, as we age, we start to lose our growth hormone. And so that's one of the things that kind of causes aging. There's some controversy in the IVF world or in the fertility world about, well, if we give you extra growth hormone, are we able to help the body repair some of the age-damaged DNA? And that's really what Omnitrope or growth hormone is said to do. I'm a believer in it, but there are some studies that say it doesn't really do anything except for increase cost, because it is pricey. I've seen anywhere from $400 to $700 for a vial of Omnitrope. Is it worth it? Well, in my opinion, I think it is. There are other studies that show, yeah, it does make a difference in egg quality. So it just depends on who you believe. But empirically, in our practice, at CNY, we do use it, and I do think it makes a difference. In the outcomes there. Hi, Jessica, asking, can you explain more what you mean by an age-appropriate dose? Yes. So a mini dose let's see, we talked about a mini dose and a high dose. So two ends of the spectrum there. And so let's say that you have someone who is 35 years old. Just pick a number. And I think the question I had before, she was 39, but let's just say 35 years old, right in the middle of the 30s. Well, a mini dose would be a dose in the 200s or so, which might be most appropriate as a normal dose for someone in their 20s. A high dose might be something in the 400s, which might be age appropriate for someone in their 40s. So an age appropriate dose would be something in the 300s that's kind of in the middle between that high dose and that very low dose. And I'm using those numbers 200, 300, 400 just as kind of a relative thing so that you kind of know where I'm talking about. It's not the high dose at a 4. It's not the low dose, the mini dose at a 2. It's the age appropriate dose, which is somewhere in the middle at about a 3, if that makes sense. Alice in Wonderland, last 2 retrievals ended in OHSS. What should I do differently this time? So number 1, metformin, I think is a big player for you, Allison. If you weren't already on it, I think you should be for your next cycle. Usually what that means is that we would want to lower the dose, and it just depends on how hyperstimulated you were, because the whole process of IVF is what we know of as controlled ovarian hyperstimulation. So you're going to get some degree, your ovaries are going to get large. Hopefully you make a lot of follicles, but we don't want your hormone levels to be so high that you're retaining a ton of water and you're bloated like a farm animal and you just feel awful for weeks at a time. What happens even more worrisome with OHSS, or ovarian hyperstimulation syndrome, is that it can really start to affect your electrolytes and your organs. People can go into organ failure. You can get some very significant laboratory type abnormalities. You can be retaining a lot of water that results in, swelling on the brain that causes people to, kind of be in a coma and people on ventilators. I mean, severe OHSS can be a very dangerous thing. So that's something that fortunately we are very good at being able to avoid throughout the entire CNY system. And again, doing, upwards of 20,000 cycles a year. A lot of people will end up having to go to an emergency room because they don't feel good, or they're worried, or they're having some pain, or they just want to make sure everything is okay, or and many of those visits are because of things related to hyperstimulation. But true hospitalizations, people who are actually at risk and sick because of ovarian hyperstimulation, happens fortunately just a half a dozen or so times a year in the entire system. So we've gotten pretty good at being able to prevent people from getting really sick with it. Kendra Smith said, thoughts on pomegranate juice and blueberries leading into a transfer to help the lining because of the antioxidants. I'd certainly say there's no harm. There is an evidence-based protocol that goes, along with it. That's been studied pretty thoroughly, and that's again vitamin D, vitamin E, CoQ10, prenatal vitamin, and L-arginine. Chronically ill mama says, does Clomid reduce cervical mucus? Well, what Clomid will do, Clomid is an anti-estrogen. So it turns down your body's estrogen levels. And as a result of turning down the estrogen level, the brain hears low estrogen. And so what does it do? It stimulates FSH, follicle stimulating hormone, because your follicles in the ovary are where your estrogen comes from. So if the ovary is, if the body's hearing low estrogen, the brain says, make more estrogen. How does it do that? It does that from the ovary by making more follicles. But Clomid can have a negative effect on the lining of the uterus because there are estrogen receptors in the lining of the uterus. Remember, it's the estrogen that causes that lining to get all built up and to make a nice, spongy, warm, juicy place for an embryo to implant. It's what I describe as the world's best baby blanket. And what knits that blanket? It's the estrogen. So Clomid can decrease the estrogen, and that's kind of what you think of as kind of the effect in the uterus. So good question there. Uh, let's see here. Sam got checked. Any supplements I should start taking before my consult? I have PCOS and I have had 2 chemical pregnancies. So, there are a couple of different ways to look at that. So, the best supplement for PCOS is called inositol, myo-inositol. It is myo-inositol. It is not something that's called D-chiro-myo-inositol, but myo-inositol or just inositol is the best supplement for PCOS. My guess there, Sam, is it's not Sam got checked. It's Sam got shanked. I'm sorry. I couldn't see it. It can't hurt to start on some inositol, but I'd say you can wait for some guidance. I saw somebody mentioned the book. It starts with the egg. That's a great resource. Or Dr. Fink's book, which is the Vitamin Victory, is another excellent place and a cheaper place to get that information. Which is better, Clomid or Letrozole? Asks Nira. Well, they both do. They do similar things. They both lower estrogen through a slightly different mechanism. Lowering the estrogen tells the brain, make more estrogen. How does it do that? By FSH. We tend to use letrozole a lot more than Clomid because of the negative growth effect on the lining of the uterus with Clomid. So letrozole is, I used to always use Clomid. So lots of experience with it, but really I think letrozole ultimately has a much lower effect on the uterine lining. So I typically avoid Clomid under most circumstances at this point. Over to our friends on Facebook. Jen asks, can you be on Ozempic for weight loss and do fertility? A family member was tested positive for lupus and put on Ozempic to help lose weight. I've been needing to get tested for it, but I'm afraid that I'll be positive too and hinder my fertility. So Ozempic or semaglutide, the other medication is Mounjaro. These are called GLP-1 inhibitors, and they are very effective for weight loss. They are very effective for some other things as well. They do a lot of good things in the body. I can help you to get those medications through Cheyenne Mountain Gynecology. If you're interested, we can do virtual, they will do virtual consults for that. However, being on the medication, so you are not supposed to be on either of these meds if you are actively trying to get pregnant. So from an IVF standpoint, we want you to be off of them for 2 weeks before doing an egg retrieval, and you should be off of them for 2 months before doing an embryo transfer. So many people do believe and feel strongly that trying to optimize your weight before getting pregnant is a good idea because you're going to gain weight in pregnancy. But there is a push-pull as it pertains to that. And that is, especially depending on age, you don't necessarily want to wait for too long because if you wait for too long, we may be suffering with egg quality in the meanwhile. My guess, and you've probably read some of the same articles that I have, that people are getting pregnant. There's this whole, what they're calling the Ozempic babies, because they're losing weight, their hormones are working differently. They're ovulating when they weren't before. Their birth control may not be getting absorbed the same. And so people are getting pregnant, on Ozempic, and it's a thing. And those pregnancies all end up getting reported. But the medication, lasts in your body for a while. And so what they just don't know is what exactly all those effects are on the pregnancy. So My guess is at some point it's going to be approved in pregnancy because they will have there's enough people taking it that they will have collected enough data that they are able to, to make some conclusions about the safety of it. But in the meanwhile, 2 months off of those meds before getting pregnant. However, if you're on the med now, you can do an egg retrieval. You are just supposed to be off the med for 2 weeks. Why is that? Well, because it slows everything down. One of the mechanisms is that it slows down the intestines and what we call the gastric emptying, the stomach emptying. And so the reason that before you do your egg retrieval is that we tell you nothing to eat or drink, after midnight is because we don't want food in your stomach. Why is that? Well, when you're getting the anesthesia and you're lying there, we don't want you to vomit. Because if you vomit, the emesis can come up and then go back down into your lungs, and that creates something called an aspiration pneumonia, and that can be very, very dangerous. And so that's why you don't eat or drink before surgery, before you're going to be getting anesthesia. Well, since these medications slow down the stomach emptying, we don't want you to still have a full stomach, even though you haven't eaten after midnight. So that's the rationale behind that. Jen, that was actually a really good question, and I appreciate you asking that. Hi to Brandy. Brandy, is fresh or frozen better for an embryo for a woman in her late 30s? I think it depends. So the fresh transfer is included in the price of IVF at CNY. So if you have enough embryos, absolutely do a fresh transfer. People get pregnant from a fresh transfer every single day. But a frozen transfer is going to have a little higher success rate for the reasons that we talked about before, that your body's been in egg making mode when you're going to be doing that fresh transfer. And so that means it may not be as hospitable to a pregnancy as it would be if you were coming back to do a frozen embryo transfer. Now, there are some scenarios where we will tell you, no, do not do a fresh transfer. We see this actually kind of really every day around here. Folks will have a progesterone level that's too high. And they say, well, I have it in my heart. I want to do an embryo transfer. I'm doing it anyway. And we say, no, your progesterone is too high. And they say, well, I can't come back there. I'm just going to do it anyway. And our answer to that is, well, look, this is your body. These are your embryos. So you really, unless it's going to be a danger to you, and sometimes like if you're hyperstimulated, it can be a danger. So then we will say, no, we are going to, we have to do no harm. And so we're not going to let you get injured from it. But, you have spent a lot of money and a lot of heart and soul and time to make these beautiful, perfect embryos. So why do you want to waste an embryo in a situation where the progesterone level is too high? And what does progesterone have to do with it? Well, the progesterone controls your implantation window. And as the progesterone level goes up, as it approaches 1.5, that window of implantation gets narrower and narrower until it's at 1.5, and then really the window closes. So if your progesterone's above 1.5, a fresh transfer just really isn't going to work. So we don't want you to waste an embryo, but people often do get upset about that and say they want to do it anyway. But in general, are there people who get pregnant? Maybe. I'm sure there's probably somebody watching who's going to say, well, mine was a 1.9 and I got pregnant. It's pretty unusual, to be honest with you. So it's just the kind of thing where we don't want you to risk an embryo. So which is better depends on the situation. I think if you can do a fresh transfer, do it. If you have enough embryos, it's included in the price. So absolutely go ahead and do it. Alicia says, I'm starting on a retrieval cycle. The doctor I'm seeing recommended Lupron on day 21 for 10 days, then start stims. Why is that? It's different than my last 2 retrievals. That's a little bit of an older way of doing it. That's suppressing you in the luteal phase. So it may help to synchronize the growth of some of the follicles. Some people don't do as well when you use Lupron in the luteal phase. So I think it probably depends on your individual situation. If you talk to the doctor um, um, who thought that was a good idea for you, then it's probably a good idea. But why would that be? It can fire up the pituitary and help you make some follicles, and also can help you to coordinate the growth of those follicles. Linda Wynn Trang says, consulting provider recommended a high bundle for my low AMH, but you recommended a mini stem. Should I change to a mini stem since I'll be going to you for the egg retrieval and the transfer? Well, so, again, two different ways of thinking there. One is, and many practices will work this way, they always start off high. I would rather see you start off low because the data shows us that, again, using very high doses of stim in folks with a low AMH may result in you not getting very much at all. Why? Well, because the receptors get saturated. Ovaries don't know what to do with all that stimulation. But the old wisdom was that if your AMH is low, we want to pour as much concoction here onto the ovaries to try to get them to respond as possible. We want to give you as much medication as we can to try to get you to respond. But that just doesn't always work. A, expensive. People can spend 12 grand on medications, B, side effects go along with that. And C, diminishing returns with higher doses. Higher is not better. In other words, it's not a linear progression that the more you use, the better you do. Whereas what we know from the European experience is that low dose tends to get you the very same kind of results as you get with a high dose, but at a much lower exposure to medication and at a lower cost. Why do we know this from Europe? What do the Europeans have on us here? Well, the answer there is because in Europe, the governments cover the IVF. But the government doesn't care if you get 20 eggs or if you get 2. The government says, we're paying for this. And so therefore, this is the dose you're going to get. Everybody gets these very low, doses. And so from that mini dose, these low doses of stimulation, they've learned that you tend to get the same outcomes, but with a lower exposure to medicine. Now, with a high dose, maybe you'll get 6 follicles, and of those 6 follicles, you'll get 4 eggs, of which 3 are mature and 2 fertilize. Just picking numbers. 6, 4, 3, 2. All right. With the mini dose, you're not going to get all 6 follicles. You may get 4 follicles, of which you get 3 eggs that are mature and 2 fertilized. So you end up really getting the same result as the high dose, but at a much lower exposure to medication. That's the rationale behind the mini dose therapy. And I think it really does make sense for folks with a lower ovarian reserve. There is no need to overspend on your medication. It may very well be that you're going to have to do more than 1 cycle of IVF. And I would much rather you be able to do that than have to spend all your money in 1 cycle just for the medications that aren't going to give you the results that you want. You know what I mean? Let's see here. Shay Nicole says, I had my transfer last Thursday with Dr. Kiltz, had my midway labs. Do the progesterone and estrogen levels determine pregnancy? I also took a test and it's positive. Well, no, the progesterone, so the estrogen level doesn't actually really matter. The progesterone level is important. Shay Nicole, if you are doing a medicated cycle, we want that progesterone level to be above a 20. If you're doing a natural cycle or a modified natural, we want it to be above a 10. If you already did a beta and it's positive, that's probably a good thing. But if you are doing HCG boosters, then you may have been measuring the level of the HCG booster. So it kind of depends on whether you're on boosters or not. But so no, estrogen and progesterone don't determine the pregnancy. But I would say that's not a bad thing to have a positive beta at this point, especially at your midways. But it makes me wonder about your um, what did I just say? That makes me wonder about that if you're using HCG boosters. Ms. Roselle says, what causes a miscarriage at 7 weeks? We have used a PGT tested embryo. The media used was from Cooper Surgical's batch that was recalled. So miscarriages can still happen even in PGT tested embryos. Why does that happen? Well, it's not a perfect system, unfortunately. It just isn't. And what that means is that they've tested from the placenta, not from the embryo itself. And even though that tells us that the placental chromosomes are normal, it doesn't say anything about all the little chemical equations that are going on inside that embryo, all of which have to line up and be working correctly in order for the embryo to grow. I'm so sorry that happened to you. That is it's a downer, but it does tell me, like we talked about in my Instagram post from yesterday, biochemical pregnancy. At least we know brain is talking, uterus is listening. So, Ms. Roselle, that is at least a half a step in the right direction. So there is some silver lining there. Folks, gosh, I just kept on talking here and we are all out of time. So I got to say, thanks so much for being here with me tonight, as every Tuesday, Fertility with Fink and Friends, because I am Fink and you are friends. And what we have to know is that this whole damn book is not the story of your life. It is merely a chapter. And what are we doing here, friends? We are here to rewrite it. Yeah. Every step forward with kindness. There is not enough kindness in this world. Every step forward with love. Look at the sign behind me there from my dear friend Jody. And most of all, know that there is hope for tomorrow. Tomorrow is a new day, and whatever happened before, we can leave behind us, knowing that the sun will rise tomorrow. God bless you all. Thanks for being here, and I'll see you next week. Good night.